Okay, so let's talk about the hard sound. So why don't we start with S1? So the S1 hard sound is going to happen when we close the tricuspid and the mitral valves. Okay, now you can imagine when we're closing those valves, we're ending a filling phase. So if we're ending a filling phase, we're getting ready to contract the ventricle. So this is going to be at the onset of systole. Okay, so we're going to hear the S1 hard sound at the onset of systole. Technically speaking, the mitral valve will actually close first and then the tricuspid valve. But really, between these two different valves, there isn't a dramatic change in the pressure gradients. And so for that reason, as they're closing, there's not going to be, a great split between the two valves. Even though the mitral valve will close a little early, there's not going to be a split that we're going to auscultate, at least not presented in board questions. And so you don't really have to worry about any splitting of the S1 hard sound, even though the mitral valve technically closes a little bit earlier. When we're listening to the S1 hard sound, we're predominantly listening to the mitral valve. So anything that can affect the mitral valve pathology-wise can change the intensity of the S1 hard sound because it's primarily generated by the mitral valve. If we wanted to hear the mitral valve, for example, where would we listen? Remember, the mitral valve is going to be at the mitral post, which is at the cardiac apex, which again is the fifth intercostal space midclavicular line. And if you wanted to hear the S1 really well, that's probably where you would want to listen, right? Because again, the S1 hard sound is primarily generated from the mitral valve. Now, if you wanted to make that sound louder or accentuate that sound, you can have the patient sit in the left lateral decubitus position. The idea here is that by doing that, you're pushing the heart closer to the skin, and then if they're in end expiration, right, take a big deep breath, they blow it out, the heart is getting pushed out back even closer to the skin. Okay, so the left lateral decubitus position in end expiration at the cardiac apex is going to give you the best clarity in terms of sound of the S1 hard sound, or the most intense S1 hard sound, so to speak. So sometimes when we're talking about the intensity of the S1 hard sound, sometimes you'll see in a board question they'll write, oh, this patient has a loud S1 hard sound. So what are they talking about? When there's a loud S1 hard sound, usually, you have your left atrium and then you have your mitral valve here. We're just going to draw it like that. That's our mitral valve. And then we have our left ventricle down here. Okay, and so the left atrium's got to take this blood and it's got to allow for passive filling into the left ventricle through the mitral valve. But if the pressure in the left atrium is very high, okay, if there's a lot of volume in the left atrium or the pressure is very high, this mitral valve, as it closes, it's going to close harder. It's going to generate a louder S1 hard sound. Just to keep things simple, because we don't want to get too complicated, but if there's more pressure in the left atrium or greater pressure gradient, what will happen is after filling, the mitral valve will tend to close louder. So you'll get a loud S1. So a situation where this might happen would be if a patient has mitral stenosis, particularly early onset mitral stenosis, then the pressure gradient is going to be higher because this valve is more narrow. And so when it shuts, it's going to make a louder sound. Okay, so the point is you get a louder sound with early mitral stenosis. A soft S1, or even an inaudible or absent S1, so I'll put soft or absent, might be in a situation where you have an immobile mitral valve. So again, here's your valve. Instead of it moving shut, it's kind of just stuck. It's not really moving anywhere. Okay, and you might have a little bit of mitral regurgitation as well because of that. Okay, so if your mitral valve is immobile, okay, you might not generate an S1 hard sound because it's not really closing very well. And that's what's generating the S1 hard sound, is the closure of the valve. This tends to happen in late mitral stenosis. Okay, so if it's a very chronic mitral stenosis, eventually that valve can potentially become calcified or damaged, and that can prevent it, or at least decrease the mobility of the valve, and eventually lead to mitral regurgitation. Okay, so what about the S2 hard sound? So the S2 hard sound is going to be produced by the closure of the pulmonic and aortic valves. Okay, so when are you going to close these two valves? You're going to close these two valves at the onset of which phase? At the onset of diastole, right? Because you just finished systole. That's why those valves were open. So now we're just starting diastole. Okay, so we're just starting diastole. Now, these valves we're going to separate into a P2 and an A2. And the reason for that is because unlike the S1 hard sound where the mitral valve pretty much predominated, and there wasn't a huge difference in the timing of the closure of the valves. The S2 heart sound generated by these two valves actually can be split because there could be a greater time difference between the two valves closing. So generally what happens is in a normal situation, what we would expect is something like this. And so again, this is our kind of our time axis here. And so as time goes on, right, we're going to have the aortic valve close first, and then we're going to have the pulmonic valve close. And the aortic valve is usually going to be higher intensity. It has to do with the pressures, again, on the left side of the heart. So the aortic valve is typically going to close first before the pulmonic valve. These valves can change in terms of who is closing first, how much distance there is between closure of the two valves, simply based off of physiologic conditions, pathologic conditions, certain body posturing. All those things can affect these two valves, and these are very commonly tested concepts because they relate to the physiology of what's going on. So here's kind of how I want you to remember this, because you can sit here and memorize these tables all day, but again, a lot of this is tested on concepts, and so you have to understand the concept of what's going on. So let me just give you my take on it, okay? So let's just look at the aortic valve, for example. So here's my aortic valve. Okay, let's just say that this is my left ventricle, and up here is my aorta. Okay, so I'm going to be ejecting blood from the left ventricle to the aorta. Here's my aortic valve. Now again, the blood's going to be going this way, right? If I have higher resistance distally from aortic coarctation, increased afterload, whatever it is, right? Higher resistance is going to cause this valve to close sooner. So higher resistance distally, all that pressure is going to, bam, close that valve shut, right? It's all that additional pressure helps close the valve. The other concept is if I have more blood volume over here, proximal, increases in blood volume will actually have the valve close later, okay? So if I have more blood volume proximally, it's going to take longer for that AV valve to close because I have more blood that I have to get through this valve. Okay, and so that's going to take a longer amount of time. So increased resistance distal to the valve is going to make the valve close sooner. Increased blood volume proximal to that valve is going to make the valve close later. And that's true for both the aortic and the pulmonic valve, and for all of these valves, really. Okay, but when we're talking about splitting, that's what we have to keep in mind. If we apply that concept, we can figure out who is going to be where in terms of these splits. So you'll see what I mean here. So the P2 is best heard again at the pulmonic post. We went through that. The aortic valve is best heard at the aortic post. So let's talk about this physiologic splitting of S2. So what you have to keep in mind for this, again, is you have your venous system here, right? You have your vena cava, and you have blood coming back to the right atrium, the right ventricle, and eventually this blood's going to go out through the pulmonic valve, right? So here's your pulmonic valve, okay? And the concept here is when you take a deep breath in, when you take an inspiration, you bring down your intrathoracic pressures. You have a negative intrathoracic pressure. When you have negative intrathoracic pressure, the heart has more room to accommodate blood because the pressure is lower. So more blood is going to come back. So with inspiration, you're going to have increases in your venous return. Okay, so with inspiration, you have increases in venous return. So increases in venous return, right? So if I have increases in venous return, what's going to happen? Well, then I'm going to have more blood proximal to my valve because I have more venous return. More blood is coming back when I take an inspiration. If I have more blood proximal to my valve, the valve closes later. So what happens? So P2 closes later. It's going to close out here somewhere. So what happened? I got a widening of my split, right? See, that's how it works. So you just apply this concept. If I take an expiration, right? If I take an expiration and I'm breathing out, okay, if I'm breathing out, I'm increasing my intrathoracic pressure so I can get that air out of my lungs. But when I increase my intrathoracic pressure, less blood's coming back to the heart, right? So I'm decreasing the venous return because the pressure's higher. So I'm decreasing the venous return. If I decrease the venous return, I have less blood volume proximal to my valve. So my P2 is going to move this way because it's going to close sooner because I have less blood volume. So it's going to narrow the splitting, right? So that's why inspiration and expiration change the location of this P2 component. The A2 component isn't dramatically shifted, it's really the P2 component that we're looking at. Now let's take that same concept that we just talked about and apply it to pathologic S2 splitting. So the wide fixed split of S2 is particularly high yield to remember its association with atrial septal defects. And I told you that typically if you're listening for an atrial septal defect, you're going to listen at the pulmonic post. Why is that? Well, let me kind of show you. So in an atrial septal defect, again, here's our right atrium. Again, here's our vena cava, right? Doesn't matter. Here's the superior, here's the inferior vena cava. They're bringing blood back to the right atrium. That's going to bring blood to the right ventricle, and then eventually this is going to get ejected out through my pulmonic valve. Okay, and that's going to eventually go to the lungs. If I have an atrial septal defect, right, I'm going to have some opening between my left atrium and my right atrium. Left atrial pressures are higher, so they're going to push the blood into the right atrium. So I'm going to end up with more blood coming down this way, right? More blood. What happens when I have increased blood volume? Just going back to our concept here, the valve closes later. And guess what? The volume of blood isn't changing because I'm breathing in or out. The volume of blood is always going to be higher because the left atrium is always pushing blood back into the right atrium. Okay, because I have an opening here. For that reason, it's a wide split, right? The P2 is going to shift over because I have more blood volume, so it's going to be wide, and it's fixed because I constantly have this blood coming back into the right atrium and into the right ventricle. It's not just coming with inspiration. It's always increased blood volume from the left atrium. And so for that reason, it's a wide fixed split S2, which is particularly high yield. Pulmonary stenosis, for example, would also be, another cause of a wide split. It might not necessarily be a fixed split, right? Because I don't have blood, coming just from the left atrium. But again, the idea with pulmonary stenosis is I have less diameter through this valve, more blood backs up, takes longer to get this blood to come through, right? Increased blood volume, valve closes later, P2 is going to move over to the right. Same concept with a right bundle branch block. It's going to take longer for that blood to get out. I'm going to have usually increases in blood volume or a longer duration to get that blood into the next chamber. Now, what would cause a narrowing pathologically of an S2 split, right? Anything that increases resistance distally. So pulmonary hypertension would cause P2 to actually shift this way. Now, if we had pulmonary hypertension that was very severe, potentially it could shift before A2. But really the classic thing that you want to remember in terms of, P2 and A2 basically switching places, so you'll have P2 come out before A2. That's called a paradoxical split. Okay, so paradoxical means that the P2 component is actually coming out before A2. So things that would cause this, for example, one of which is going to be severe aortic stenosis. Again, if I have severe stenosis distal to my valve, if this aortic valve has severe stenosis, I'm going to have a backup of blood in the left ventricle. It takes longer for this valve to clear all of this blood. The aortic valve will actually delay its closure and move that way. So the pulmonic valve would actually come out first. So it would look something more like this. You'd have your P2 here, okay, and then your A2 would come after. So it would look something like this. The reason it's called paradoxical is because you can imagine if this, if a person had severe aortic stenosis and they had, significant delaying of their A2 component because of the stenosis and the blood volume that's built up in the proximal chamber, what would happen is if that person took a really deep breath, inspiration, instead of getting widening, they'd actually get narrowing because the increased blood volume going back to the right side of the heart would delay the pulmonic valve from closing, and it would actually narrow these two. If the aortic valve was in front of the pulmonic valve in terms of when it closes, that would be a widening because it would have delay of the pulmonic valve and inspiration. But when the pulmonic valve closes before the aortic valve and we delay that, that's actually a narrowing. So that's why it's called paradoxical. So if you have in a board question, if they tell you a patient took a really big inspiration, but they had narrowing of the two S2 heart sounds, that means that they have a paradoxical splitting of S2, meaning for some reason the aortic valve is either very delayed or the pulmonic valve is closing much earlier. And usually it's because the aortic valve is delayed. That would be severe aortic stenosis or a left bundle branch block, right? That's primarily going to affect left ventricle. Or it could be, like I said, anything that increases resistance distal to that valve would make it close sooner. So if it was pulmonary hypertension, that can also move P2 forward. Okay, so let's talk about the S3 and S4 heart sound. Now, there's some things that you have to remember. The way I want you to think about it, and we're just trying to think about things kind of in a simple way without getting overcomplicated here. S3, I'm thinking about volume, okay? So in S3, I'm thinking about volume. S4, I'm thinking about pressures, okay? And here's kind of what I mean by that. In a patient that's volume overloaded, I'm thinking a lot about S3. Okay, so in a patient that has a lot of volume in their ventricles, you think about S3. Now, normally you have your S1, which we already said the S1 is going to kind of kick off systole, right? So this is going to be the onset of systole. And then, you're going to have your systole phase, and then you have S2, which is closure of the aortic and pulmonic valves, right? So then you're going to have your diastole, okay? Now, S3 is usually going to happen right after S2. So sometimes it's called the S3 gallop. Okay, so after S2, sometimes it's called the S3 gallop because it's kind of galloping behind the S2. So it's going to happen early in diastole, again, due to high ventricular volumes. So when I open up my mitral valve and when I open up my tricuspid valve, if I have a ton of volume sitting in that left or right atrium and that volume starts pouring down, I might get that ventricle to fill really quickly and tighten against the chordae tendineae, and that's going to produce this S3 heart sound. It's from rapid filling from very high volumes in general. Okay, again, both of these, by the way, both of these are best heard at the cardiac apex using the bell of the stethoscope. Okay, so not the diaphragm, the stethoscope, but the bell, classically, again, at the mitral post, cardiac apex usually. And again, same thing for accentuation. It's no different than what we talked about before, again, at the mitral area for the reasons we already mentioned. Now, the thing that you really want to remember about these two is that the S3 can be normal in the young, okay, and the fit. So like an athlete or a marathon runner, they're going to have a very efficient heart in the sense that they might be moving a lot of volumes and have a really low heart rate because of higher levels of muscle oxygen extraction and overall efficiency of myocardial work. So for those reasons, you might actually hear that tensing because it fills so fast. Okay, but not because they're volume overloaded, just because their heart is very efficient in moving that blood volume. In pregnancy, this is sometimes thought to be a high output state, so is thyrotoxicosis. So certain high output states can also generate an S3 because, again, it all has to do with the volumes. If you're moving high output, you're moving a lot of volume, a lot of blood volume, that can generate an S3, again, from rapid ventricular filling, tightening of the chordae tendineae, tensing, I should say, of the chordae tendineae. That's very classic. Okay, so again, that's more on the physiologic end. Pathologically, it's classically going to be associated with systolic heart failure. If you have a low ejection fraction, you can't get blood out of the left ventricle, right? Because that blood is kind of just sitting there, you're going to have a backup of blood. You're going to have high volumes in systolic heart failure. This is a dilated cardiomyopathy usually. Okay, so the heart's very dilated. It's not going to be thick like a ventricular hypertrophy. It's going to be very thin, and poor contractility is going to be kind of the basis behind it. Okay, so mitral regurgitation because you're having buildup of volumes coming back. And so, when you think about mitral regurgitation, a lot of people think, okay, well, preload's got to be low because I'm regurgitating blood backward, right? But not really. You actually usually will have high preloads in mitral regurgitation, high blood volumes, because when the left ventricle goes to contract, that's pushing the blood, back into the left atrium. So you're getting blood back from the left ventricle into the left atrium, as well as all the blood coming from the lungs going to the left atrium. So your left atrium is massive, and as soon as that mitral valve opens, it dumps all of that blood back in. So the left ventricle is constantly getting blood that it already ejected, right? But only to the wrong place. It ejected it to the left atrium. And so when you have mitral regurgitation, you're constantly maximizing your volume in the left ventricle, and that's actually volume overload. That's a high preload state. And so that's classically also associated with an S3. Aortic regurgitation, again, blood volume coming back to the left ventricle. Increased left ventricular volumes associated with an S3. So how does that differ from the S4? So the S4 heart sound is produced by the atrial systole phase. So normally in diastole, we're going to open our mitral valve. We're going to rapidly fill the left ventricle. That's where we're at here. That's S3. And then after we do that, we're going to have a slower filling phase, and then we just want to get the last bit of blood out of the atrium. So we're going to contract. We're going to contract down to get the last bit of blood out before we start systole. And if we can hear that contraction typically we'll call that an S4. And it's not actually the contraction of the atrium that you're hearing, it's the blood going from the atrium hitting a stiff ventricular wall that makes the S4 heart sound. So again, when you have this atrial kick, if we have a very stiff ventricular wall, that might produce this heart sound because that stiff ventricular wall is associated with increases in left ventricular pressures. So this is primarily going to be associated with a poorly compliant ventricle. Remember, compliance, we just talked about this in the last video, the compliance is equal to the change in volume over a change in pressure. Okay, so if I can't really change my volume because my ventricle is really stiff, what happens is my pressures are going to get very high. And if my pressures are really high, right, my denominator is going to be here, pressures go up, compliance is going to go down if I can't change my volume because it's stiff. Okay, so a very poorly compliant ventricle is associated with very high pressures. Very high pressures are going to be associated with ventricular hypertrophy and an S4 heart sound. Okay, so that is the idea. Now, this can be normal in the elderly. It's almost always abnormal in the young, but it can be normal in the elderly. There could be age-related hypertrophy, right? Classically, more of the diastolic heart failure. This is going to be more of the ventricular hypertrophy as opposed to the dilated cardiomyopathy that we'll see with S3, and we'll talk about that more in heart failure. But in general, you can have hypertension cause either kind of heart failure, but usually chronic hypertension is more associated with diastolic heart failure, ventricular hypertrophy, aortic stenosis for the same reasons. It's all about high pressures. We're not talking about volume. We're talking about stiff ventricle, high pressures, poor compliance.